Good afternoon. My name is Dorothy Burridge, and I'm the Regional Education Coordinator with the Central East Stroke Network. And on behalf of the Central East Stroke Network, I'd like to welcome you to our webinar today on smartphone application for arm recovery, presented by Dr. Mark Bailey. Before I turn the presentation over to Dr. Bailey, though, I just have a couple of messages for you. There is a handout for this presentation, which has been saved in the handout section of the control panel. So you can just go ahead and click on the handout to download it. You will also see on the screen, and there is a message in the chat box, that in preparation for this webinar, please consider downloading the ViaTherapy app. It is available free through the App Store or Google Play, and it can also be downloaded through the www.viatherapy.org website. We encourage you to submit any questions today by typing them into the questions section of the control panel. So I'm happy to say our presenter today is Dr. Mark Bailey. He is currently the Medical Director and Senior Scientist at the Brain and Spinal Cord Rehabilitation Program at Toronto Rehab. He is Professor and Saunderson Family Chair in Brain Injury Research at the University of Toronto in the Division of Physical Medicine and Rehabilitation, Faculty of Medicine. Mark's research focuses on understanding how to speed brain recovery through exercise, virtual reality, telerehabilitation, and functional electrical stimulation. Importantly, he has explored novel implementation strategies to bridge the knowledge-practice gap by making best evidence available to clinicians through smartphone apps and best practices guidelines in stroke, concussion, and brain injury. His work has redesigned the stroke and brain injury rehabilitation systems in Canada. So thank you, Dr. Bailey. I will turn the presentation over to you now.
Thank you so much. We'll just do the handoff if I can do it. And I will show my screen, and we'll just confirm in a moment that you can all see it. Sorry, I'm just going to make sure I put it in the beginning. Can everybody see it? Dorothy, is it okay? Are we good?
See it. Thank you.
Perfect. Okay. So thanks everybody for joining. I'm very excited to tell you a bit about the smartphone app, and this will be a very virtual interactive presentation because we want you to actually use the app, and there are some videos embedded. Hopefully they'll work for us, and that you'll be able to kind of get a sense of how the app works. And so by the time we finish, I hope that we will be able to sort of understand a little bit of a model for prognostication of recovery following stroke, particularly for the arm, that you'll be able to use the smartphone app to identify some best practices for each of your stroke patients, depending on the time post-stroke and their severity of impairment. And then we also want to show you how you can use the app to identify key issues such as the dose of intervention, what are the contraindications, what outcome measures could be used, and also other features that are in the app. So we're going to start with a case. Kevin is a 56-year-old gentleman who suffered a right middle cerebral artery stroke, and within the last, let's just say for the sake of argument, I need to change the date, but let's just say he injured it on March 7th, 2018. He has minimal left lower limb involvement and reasonably good leg function, and he has no significant visual spatial neglect. When we look at his arm, he has slight shoulder abduction and some active shoulder flexion. He has movement patterns dominated by compensatory trunk lean and shoulder shrug and no active hand movement. He experiences pain at rest during night and on external rotation, and he has no swelling or significant spasticity and no extension of the fingers. So the question to you is, what's the probability of Kevin having some dexterity at 6 months? So he's now, as I mentioned to you, he's about a month and a bit, just under a month from his injury. And so the first objective was to discuss strategies for predicting arm recovery post-stroke. So this is from one of my colleagues, Gert Kwakkel, who works in the Netherlands, and what they did is they just to illustrate, they looked at the Action Research Arm Test score for a variety of people who were randomly selected with an upper limb weakness following a stroke. And you can see that there's a certain proportion of the people who rapidly got back to a high score on the RS and did well. And then you have another group who took a long time, but then started to improve. And then you have another group who did poorly and continued to stay poor, have poor arm recovery. And then there's a middling group. So our challenge is probably in this middling group to try and identify what should we do for this group and what is the prognosis. Sorry, I'm just having a second. My computer is now, for whatever reason, I know what it's doing. Sorry about that. If we can, I'm gonna go to next. Okay, so if we look at this, what they did in this study was they followed people at 0 days, like at onset, 2 days after, 5 days after, 9 days after, 12 days after, and they started to wonder what would be determinants. What they included is people with ischemic first ever hemispheric strokes. They took the localization of the stroke by CT or MRI. They had to be suffering from hemiparesis. They had to be seen within 72 hours. They could or they didn't. It didn't matter whether they had TPA or not. And they had to be 18 years or older, and they followed them at 28 weeks. And so in view of the question I asked you before, what's the probability of having some dexterity? If your Action Research Arm Test score was less than 10, you had a 30% probability of having dexterity. And if your Action Research Arm Test was greater than 10, then you had a 70% probability of dexterity. And here's when you look at this a little bit, what they looked at things that were actually tools that you could take from the RAT. So specifically finger extension and shoulder abduction. And you can see that if an individual has at day 2 finger extension and shoulder abduction, the probability of having some dexterity in the arm is 98% at the 6 months. On the other hand, if an individual had finger extension, but perhaps not perfect shoulder abduction, they also still had a good prognosis with 89% having some dexterity. And even having some shoulder abduction at day 2 was an indicator of a better prognosis. But if you have no shoulder abduction and you have no finger extension, your prognosis for having some dexterity is only 25%. Okay. So they also looked at day 5, and they saw similar relationships to the relationships that they saw at day 2. But perhaps for those who still had no movement at day 5, they had a better prognostic indicator that unfortunately this person was not going to do well. Similarly, at day 9, you see that you start to see the trends continue to be the same. And so when we look at this general spread of individuals who are recovering, and this is sort of similar to what I showed you before, you see that there are some people in the first 3 months who change. They are improving. There's a group that start in the low and then they start to improve. And then there's a group who stay low. But we can see that when we get to the 3-month point, we are pretty sure that they're going to stay for the most part where they are, or perhaps slightly worsen. So this indicates to us that in this cohort of people, that once you get to about 3 months, you can see some people, you can see where people are going to be at. So what do we mean? So, and again, when we follow this, how long it took till they got voluntary extension, you can see that we kind of get to know by 12 weeks, most people have stabilized. So what do we get? Well, we get some individuals who we would call if this is sort of the prediction, we would get some people who you would consider to have a bad prognosis initially, and yet they actually turn up and and after starting out poorly, do well, and actually are what we would call false negatives. And then there's another group who are true negatives who started out poorly and stayed poorly. So they said, okay, so how could we better understand, if we only know the shoulder abduction and we only know the finger extension, how could we do better to prognosticate recovery? So they started to look at some of the other things in their data set, and they found that if you had an initial poor prognosis and you had good motor function in your limb, you would have a good prognosis for arm recovery. Whereas if you had very poor lower limb function, not surprisingly, the territory is larger, you would have a poor recovery. Similarly, if you had no neglect and you had no sensory deficit, your predicted probability of doing well was 94%. If you do have neglect and you have a somatosensory deficit, then your prognosis is poor. So clearly, when we add to this shoulder abduction and this finger extension some of the other things that are readily available to us, lower limb function, presence of neglect, and somatosensory deficits, we can then take some of those false negatives and move them into more clarity. So this is named then the SAFE model for shoulder abduction finger extension. So at the initial first days, we can give people a poor prognosis or a good prognosis. And you'll see that 34% have a full recovery if they have a good prognosis. And some of the people who are initially described to be poor recovery will continue to have a poor recovery. These are the true negatives. Whereas those who are thought to be poor but have a partial recovery are false negatives. And then, of course, we have some group who make a partial recovery. So let's go back to Kevin for a moment. Kevin had some shoulder abduction and some active shoulder flexion. And he had no finger extension. So going back to him, he had some shoulder abduction and he had no finger abduction. He has a 71% chance of having some dexterity on the Action Research Arm Test at 6 months post-stroke. Okay, so the other thing is, Kevin also, in addition to having some shoulder, he actually only has slight lower limb involvement, and I told you before that he has no significant visual spatial neglect. So therefore, he has a negative prognosis initially, but he has a relatively good prognosis because he has reasonable lower limb function and no neglect. So there are also, just to make you aware, that there are emerging, and we really want to enhance the app that you're going to see shortly by looking at some of these new models and embedding it in the app. And Kathy Stanier, who's part of our group, has developed a tool called the PREP2. And the PREP2, the only challenge for those of us who work in clinical practice is that it uses transcranial magnetic stimulation as one of its indicators of prognosis to assess the integrity of the corticospinal tract by trying to elicit a motor movement using a magnetic stimulation over the cortex. Of course, many of us do not have access to TMS in our JLE clinics, and so that obviously is a limitation of this, but we see the future will include biomarkers and imaging findings to help us to prognosticate. But today, I wanted to emphasize that we're going to use a smartphone app to identify some of the best practices depending on the time post-stroke and severity of impairment. So just to give you a little bit of historical perspective, this project was co-led by myself and Steve Wolf with a very large group, which I'll introduce you to. And it began with Steve sitting down with Paulette Van Vliet and Val Pomeroy in England saying, we really should do something about all this research that we have and how nobody's using our research. We're publishing all these trials and we think that, things are not going well. In the US, there was an imperative because the insurance agencies were not funding research. So Steve came to us because he was on the scientific advisory committee of the Canadian Stroke Network and said, the CSN has been leaders in setting up standards and rehab knowledge translation. Why would you be willing to support something? And they did. They gave us some money to host a meeting in the October of 2010 where we got a bunch of people together and we reviewed the previously published stroke guidelines. We defined working groups and we started to set out to look at what the evidence was. We were meeting regularly to try and update this, and I was lucky enough to secure some funds from the UHN Toronto Rehab Foundation to develop an app prototype, and we documented that in a publication which is available to you, the process, which is in Physiotherapy in 2015, and in the process of developing it. And we launched it on the Apple App Store just about a year ago, and I'm proud, and we're quite pleased to say that it's been downloaded about 6,500 times already, and hopefully you've downloaded. Just to give you a sense of who's on the team, many of you will know Jana Singh, Carol Richards, Marilyn McKay-Lyons, who are Canadians involved in this, Nancy Selbach, Michelle McDonald. We had a group, Gert, who you heard about already, who did the app, who did the SAFE model, Carolee Winstein, who published the a number of the trials, and Catherine Lang, who's looking at repetitive training, Mindy Levin, who's an expert in FES, and Charlotte from Sweden. So we had a truly international group from the probably Western world developed countries, but still a broad range of expertise. So why did we want to use an algorithm? Well, it provides a decision-making process. It should be based on clear assessment criteria that were chosen because of the prognostic significance, and it should consider our evidence. So going back to our SAFE, we came up with an underlying question that you'll see as we go through the app. Can the person produce any voluntary muscle activity in the upper limb? And if the answer to that question was yes, then we would ask a second question, which was return of shoulder abduction and elbow extension simultaneously. If the answer was yes, then we would ask another one. If we say no, then we say not yet, because we wanted to make sure that we know that maybe the arm recovered. So what's working in the background is the app is a set of treatments that are applied to each of these answers to the question. So the evidence is segmented so that you know that if you said yes to this, then you land up, and you said no to this, then you landed up in a treatment in box 2, which is what the things that are appropriate for that kind of patient. So this is working in the background. As you know, we don't really always worry about what's working in the background when we're dealing with information technology, but we wanted you to have a sense of how we set up the evidence. We also recognize, as Gert highlighted in his study, that at about 12 weeks, you have to review the goals because people stabilize and they get into a more chronic phase. And therefore, the treatment should be different after 12 weeks as opposed to before 12 weeks. Okay, we were very lucky. We interviewed 5 app developers. We selected the Pivot Design Group, and they've been great partners with us. They've had some experience in app development and health with kidney disease and other things. And they really taught us some of the things that were critical, things like the user experience. So they went into the gym and they interviewed therapists. They developed a prototype which designed, and they tested it in the clinic. They had excellent awareness of how to incorporate things like tailoring the evidence using filters, and they advised us on how we might use the role of icons in the STAR system, which I'll talk to you about. So now, having spent about 20 minutes on the background, I wanted you we'll do a little bit of a exercise with a startup, which is, we're going to show you a video. Hopefully it's visible to you, and the answer you have to answer is, can the person produce any voluntary movement in the affected upper limb? And the answer is either yes or not yet. This is a really amazing skill testing question. So if I can get this to work, I will play it. And this lady is attempting to move her arm. So the answer is yes. In the chat, you should be saying not yet. Okay, We're just going to go to the next slide. So now this is the second question that is in the app, prompted to move his shoulder. If we can play it again. If you're really smart, you'd say yes to the next one. So that is with, or the third question raised is, with the forearm prone on a table and the fingers unsupported, can the patient initiate finger and or thumb extension 3 times within a minute? The answer is yes or not yet. So let's see if this video works. Let's try it. Okay, so let's try another one. The answer to the previous one was no. Patient could not. With the forearm prone on a table and the finger support, can the patient initiate finger or thumb extension 3 times within a minute? Now we know that his fingers are supported here a little bit, but the answer in this case would be yes. Just stop, and I'm going to ask, I know that Dorothy and Donalda will be looking at the chat. Is there any questions at this point in time that you have? Okay.
No.
So now we're going to, sorry, go ahead.
No, it's Dorothy. I was just saying no questions so far.
Okay, thanks a lot. We're going to keep going. I guess I was clear, which is great. So now we're gonna go back to Kevin. He had his stroke 4 weeks ago. His goals are to achieve independence with dressing, showering, and using his left arm for meal preparation and maintaining active and passive range of motion of the left arm. Okay, so let's ask, can Kevin produce any abduction? Okay. Okay. So now I'm going to ask you, I'm going to spend a couple of seconds giving you some time. The Therapy app. Hopefully most of you have downloaded it on your smartphone or tablet. And you will see the first page you arrive at is an agreement to give us your first child. No, just joking. Basically, agreement that you understand that this is intended to provide the best evidence, and that we recognize that you are responsible for making clinical decisions. If you want a little more background about the app, you can click on more about this app, which is on the face page of it. But I'm going to encourage you right now to go on to say, I agree. And now that you've said yes, the first question you're presented with is, was the onset of the stroke within the past 12 weeks? And if you were listening to me, you'll realize that the answer should be yes. The next question is, does the patient have shoulder pain, or are they at high risk for shoulder pain? And the answer in this case will be no. In this case, he gets a little, so let's go back and say yes before you click on start. And he's not yet had any finger extension. So let's go into the app. And this is what you will see if you haven't yet seen it. And this is what you should see when you've clicked on it. And so I'm going to get you now to go ahead and click on start. So now you will see a series of further questions that I already introduced you to. And if you're really quick, you will have answered yes, that he can produce some voluntary movement against gravity, that he can produce shoulder abduction against gravity, and that no, he cannot move his fingers. What you should then see is the opportunity to click on next. Everybody watching? Okay. So when you go to the next, now we're going to navigate the app a little bit. So the first question for all of you is, how many treatments are recommended by this level of level of impairment? So I want you to look at the page you landed on, which should say interventions. And it also should read, the patient does not demonstrate functional finger and wrist movements, but further recovery of hand function is possible. Okay? So if you were really doing well, you will have noticed that there are 10 recommended treatments, okay, for this level of impairment. Okay, the next question for you is, what is the level of evidence for each treatment? So if you scroll through the app, you will see the letters A for a lot of them. A means that there is at least one randomized controlled trial for a number of these treatments. So you'll see that motor imagery, strength training, task-specific training, electrical stim, EMG activated electrical stim, mirror therapy, sensory retraining, and some robot-assisted training all has at least A-level evidence. Okay? So let's go to the next question. So this is what you should have seen. Again, recommended 10 treatments. You will have seen the letter A beside them all. So far, so good? Okay. How did we get to the intervention? So these interventions, what we did was we reviewed the research evidence from a number of sources, the Stroke Rehabilitation Evidence-Based Review, Stroke Engine, and we compiled the list of interventions based on the expert opinion from our working group. And each working group updated the evidence until March of 2015. And we are currently in the process of updating all the evidence based on the last 2 to 3 years, which will be embedded in the app. Okay, so this is work by Jan Verbeek, and what she did is she did a systematic review of all of the treatments that are within the evidence, and you can see that this is, for those of you who are used to seeing these kind of plots, if it's around the 0, then that means that there's no effect of these treatments. If you go to the right side and that it is in the positive, then that means there is an effect relative to control groups in the research. So you can see, if you look at this plot, that the things that come up with meta-analysis support are those that are falling to the right-hand side. So things like constraint-induced movement therapy, low-intensity constraint-induced movement therapy, robotics, mirror therapy, all fall on that right side, and you can see the effect size. So that's underpinning the app. And so when you see a letter in it, what you're seeing is that there is a, B, or C written. So A means there's at least one randomized controlled trial, meta-analysis, or systematic review. B means there's at least one cohort comparison, case study, or other type of experiment. And C means it's expert opinion. That means we as a group thought it was a good idea, or we recommended against it. So that gives you a sense. If you're familiar with this grading system, it's still used for the most part by the Canadian Stroke Best Practices. So now you might ask, okay, so I'm a busy clinician, I can't do all these 10 recommended treatments. So if you only had 30 minutes of therapy time, which are the top 2 therapies judged by the expert to be most important for Kevin? So the hint is, note the star rating. So you will see that beside motor imagery, there's a 4-star rating. And similarly, by strength training, there's a 4-star rating. Task-specific therapy, there's a 4-star rating. And even though it has A-level evidence, there's a 3-star rating for electrical stim, probably because considerations like feasibility and time are starting to enter into the equation. So here's what you should have seen, and here's where the star rating is. So we're going to continue to go on, and I would encourage you to continue to use your app as you do this, because it just gets you familiar with how to use this for. So what I'm going to ask you to do is click on strength training. And you should land up with a screen that looks like this. And you can see that we have a very brief overview of the benefits. So what does strength training do? It improves strength of the proximal upper extremity muscles. Who is it for? So what we did is we looked through all the evidence and we found out who was included and excluded from all the trials, and we can see that strength training is appropriate even for people with inattention or neglect, people with apraxia, people with significant language impairment, and all those with cognitive issues. What's the usual dose? At least 2 times per week for 4 or more weeks. Can it be done in groups? Yes. And can it be administered in self-administered? Okay, so I'm going to ask you now to back out of strength training, and you should now see the intervention screen. And you may recall that I mistakenly said that Kevin did not have shoulder pain when he does. And now I'll ask you, what are the recommended treatments for his shoulder pain? So currently you should be seeing the recommended treatments for his thing, but if you click on shoulder management, you can now see the recommended treatments for shoulder pain. So I'm going to, for those of you who aren't following along, I'm going to take you to that screen that you should have seen. And you can see that in his screen, we have education and training for the patient and family regarding care of the upper extremity. We have gentle mobilization. We have electrical stim. And then if you scroll down, you'll see analgesic medication, a team-based model of prevention, that you should avoid strapping because it's not recommended, and that if people develop complex regional pain, they should be treated with prednisone. And if they have a lot of spasticity, they should be treated with Botox. Okay. My third objective was to use the app to identify key issues such as the dose of intervention, the contraindications, etc. Okay, we're going to do another case study. This is Mick. He's an 82-year-old gentleman who suffered a right middle cerebral artery territory stroke 2 months ago. His goals are to eat with cutlery and feed himself, to dress himself independently, and to return to making things in his shed. Okay, so let's open the app. Again, I'm going to get you to back out from interventions and back out to the front of the app. And again, we're going to ask the questions, was the stroke onset within the past 12 weeks? Yes. Does the patient have shoulder pain, or are they at high risk of shoulder pain? You're going to click on no, and then you're going to click on start. Okay, first question. In a seated position, can the patient produce any shoulder abduction against gravity? You've seen Mick before, but we're going to show you him again. Okay, I'm going to show you. So we'll say yes to this. I'm going to go on to the next slide. And we also, the next question is, in a seated position, can the patient produce any shoulder abduction against gravity? The answer will be yes. Now we're going to watch his hand, and we're going to get him to see if we can get him to move it. And the answer is now yes. So in terms of his current function, he has active shoulder flexion and abduction. He's weaker proximally than distally. He has good sensation and no increased muscle tone. He can produce some finger extension, but has no shoulder pain. So now you've answered three of these yes, yes, yes. I'm going to get you to click on the app and start it again. And I'm going to ask you to think about how many key treatments have been recommended at this level of function. So remember, These individuals are mildly affected early after stroke. They can move against gravity at most upper extremity joints and can make some fractionated movements of the hand and wrist, but may still have challenges undertaking functional tasks. So if you were on the ball, you will have ended up with 6 treatments recommended for this gentleman. And you'll see of note that shoulder pain does not appear on the app. Next question, what are the top 2 on the list? So if you look at our star rating, you'll see that strength training is also recommended again. And then you'll also see that task-specific training is also recommended in this individual. Okay, I'm going to get you to click on task-specific training for a moment. Okay, let's look into the app a little bit. What are the contraindications to task-specific treatment based on the exclusion criteria in the literature? I'm going to get you to scroll down to the bottom of the app, of the page, about task-specific training. And you're going to see the inclusion and exclusion criteria. And let's click on it. Okay, so what you'll see appearing is not studied. It's applicable to most people in this group. Inclusions, all patients in this group. Exclusions are people with substantial neglect and aphasia are generally excluded from the research trials. While they're not necessarily excluded by the experts, most of the people, when you look at the research trials, they're not included. I'm going to get you to back out again to task-specific training again. What is the dose? So the dose, the usual dose, is 30 to 60 minutes daily, as you'll see if you are on task-specific training. I'm going to stop just for a moment. Nobody's been frantically typing messages, so I'm assuming that I've been elegantly clear. But I'm gonna show you now. We're gonna move into next how you might apply the filters. So back out of the app to the treatments for this level of impairment. So we're now back at task-specific training. No, sorry, we're now back at interventions. And I'm gonna actually to apply a filter. So there's an orange bar at the bottom, which you're gonna click on, and you're gonna see a number of selections. You're gonna see show interventions that can be self-administered, provided in groups, show interventions that are appropriate for patients with inattention, neglect, apraxia, cognitive issues, or significant language impairment. So now I want you to apply a filter for the fact that it can be administered in a group. How many treatments are now appropriate for this patient? If I'm going to apply it in groups, you can now see that there are 5 treatments that are recommended for this gentleman. They include strength training, task-specific training, modified constraint-induced movement therapy, motor imagery, and video gaming. Here's what you should have seen. That's what it should have looked on when you clicked on Provide in Groups. Okay, so now I'm going to get you to go back to the filter page, and I'm going to get you to remove the filter for the group, and now click on that to remove it. We go back to 6 matching treatments, and now I'm going to get you to click on cognitive issues. How many treatments are appropriate? Okay, so this is what we did. We clicked on cognitive issues. There are now 4 treatments that are recommended. Those include strength training, task-specific training, sensory retraining, and video gaming. So this is a group who has some cognitive impairment, can still do a number of things despite the fact that they have cognitive impairments. So my next objective was to use the app to identify outcome measures that could be used to measure progress. So what we did to generate outcome measures for each box is we had an outcomes working group with Bob Teasel, and we went through every single paper that had been published with each of the evidence, and we took the interventions, and what we did is we took the outcomes that had been used in each study, and we put them in the format of the International Classification of Disability and Function. So I'm going to get you to click now on task-specific training. We're still in the app under this guy who had movement in his arm, no shoulder pain. And I'm going to ask you to look and click on, scroll down in the page to outcome measures. The question now for you is, what are the impairment level outcome measures that have been used for this intervention? Similarly, I'm going to ask you, what are the activity level outcomes that have been used for this intervention? So, if you got to this, you should have got that the impairment level outcomes are grip and pinch strength, the motor assessment scale, the Purdue pegboard, isometric torque at the shoulder, elbow, wrist, the Fugl-Meyer, the TEMPA, and under activity, you will have seen that the TEMPA appears again, but you'll also see Wolf Motor Function Test, the Box and Blocks Test, the Action Research Arm Test, and the Barthel Index, and then under participation, you'll see some of the quality of life scales that you should see. So, the challenge of this is we know that clinicians, we hope that clinicians will be using the app in the clinic. I hope that I've shown you that that it is relatively easy to access. It probably should take you in the clinic setting, in the clinical setting, a matter of 30 to 40 seconds to get to the recommended treatments for your patient. It does not replace the art of delivering the therapy. And we are actually going to, in the next iteration, if you download the app and you stay with us, we are going to include videos on how to do each of them in the next couple of months. So we've got the team to videotape sensory rehabilitation. We've got the team to videotape some of the things, and the app, an update of the app will be occurring shortly. Doesn't replace your clinical judgment. We recognize that there are barriers to using some of these interventions, such as the time you have with patients and the length of stay, some things like cost of equipment and robotics, and we know that staffing for things like the signature constraint-induced movement therapy is a problem. So in conclusion, the prognostication for arm recovery is possible early post-stroke using shoulder abduction and finger extension, but is most evident by 12 weeks. The VIA Therapy app provides clinicians with therapeutic guidance based on the stage of recovery and time post-stroke. And I want to acknowledge the team, the Canadian Stroke Network, the Toronto Rehab Foundation, the Heart and Stroke Foundation, Canadian Partnership for Stroke Recovery, who are supporting the uptake of the upkeep of the app and the updating of the app and the new videos that are going to come. Our app developers, Pivot Design, and if you want to know a little bit more about the app, there's some on the landing page. There's videos of how to use it, and you can follow me on Twitter. I'm going to open it up for questions and see if anybody has any questions about using the app and any complaints or concerns. I'd love to have your feedback. I know that it's a bit awkward to type, but we would really appreciate any feedback that you have for it so far. I think that's it.
Thank you, Dr. Bailey. So we'll just look and see what kind of questions come in the next few moments.
Okay, thanks. I guess we were really clear.
Dr. Bailey, this is Janelda. We did have one question, and that was, does the app need data or Wi-Fi to work?
So the app is a native app, which means at first we thought that you would have to have the app and you'd be logging in online, but we found that a lot of people didn't have Wi-Fi, and so the app is what's called a native app. The whole content of the app is downloaded on your phone, and so you do not need it. We're still debating with the videos whether or not they're going to need an active live connection, because if we download it with the app, the video may need a fair amount of memory. And so we're thinking that what we will do is probably have a YouTube or a website where when you click on the video, you will need a Wi-Fi connection to get the video. But everything else in it is a native app, which means you've downloaded it and the content is on your phone.
Okay, so we have a question from Ashley. The question is, in the shoulder management part of the interventions, for education and training, would you consider adding what the best practice is for clinicians who are new to the field?
Sure, that's great feedback. You know, some of this stuff we hadn't really put in, but I do believe that in the video, some of the people have put in what the education will include. But thanks for that feedback. That's a great idea.
Okay. So Aaron has also asked, what exactly do you mean by shoulder strapping? Do you mean using a sling?
No, we mean actual strapping with like a tape or putting one of those orthoses that is really like it's, you know, you're actually strapping them to try and get them reduce subluxation. There isn't much evidence that it helps, possibly some evidence that it may be harmful, but there's really not much evidence that it helps. So taping and strapping are not recommended.
Okay. And are there any guidelines on the app regarding clients with reduced sensation?
So what you'll see when you apply the filter, if I remember correctly, is that there should be some, for people who have neglect, we've tried to give people advice. If a person had a profound sensory loss, then you would treat them as if they have a neglect, probably. So if you filtered it and they have profound sensory loss, then treat them as if they had a neglect. Even if the sensory loss was due to a primary sensory problem, like perhaps diabetes or something, or, you know, whatever. But that would be my recommendations for you, but that's a good question that we'll see if we can clarify in the next iteration of the app.
Has there been any thought to developing a similar app for other impairments, such as lower extremity impairments or anything like that?
Yes, lots of them. We are proposing to our group, and some group from an international group of researchers is proposing to develop a lower extremity app, and hopefully the Canadian partnership will agree that it's a good idea. We've already looked at a number of funding sources, but that's definitely in the offing. One of the challenges with this, we believe we can do this for lower extremity, and those of you who are aware of some of Kathy Stenier's work, she's done some work with what's called the TWIST algorithm, which is done at day 2, and it looks at some things about trunk and other things that seems to be predictive of people's gross walking outcomes. But we think we can prognosticate the evidence for lower extremity a little bit. So yes, we're thinking of that. Originally, we would love to package the evidence for cognitive rehab after stroke, although it's a lot less rigorous than ARM. As you'll probably know, more than 50% of the research is in motor recovery after stroke. So we're going to stick to motor recovery first, and then we're going to go to perhaps other areas, cognitive, aphasia. But that was the original way that our approach was thought to be, because we feel that this is the new way of doing guidelines for rehab. We feel that, you know, when you say thou shalt do exercise or thou shalt do mental practice, and you don't tell for whom it's appropriate and you don't know who it's not, that's not very helpful. And so we believe that this is the future of guidelines for rehabilitation. So we definitely would love to see this happen for a larger number of studies and areas of research.
Okay. Currently, we don't have any other questions in the box.
Okay. Well, thanks.
So I'd like to take this opportunity to thank you very much for taking the time to present today. And I'd like to thank all the attendees for participating as well. I hope you'll each take a few minutes of your time to answer the survey that's going to appear at the completion of your webinar. And thank you again to Dr. Bailey, and I hope you enjoy the rest of your day. So thanks very much.
Very welcome.
Thank you.
Bye.